Today I'm going to speak about potential value of biomarkers in pediatric renal transplantation. These are my disclosures. It's all in terms of research grant support, as you can see. In essence, relatively little is known about the validity, utility, and reliability of immunological biomarkers in pediatric renal transplantation. There are some unique clinical characteristics of pediatric organ allograft recipients that suggest that immunological biomarking would be particularly helpful. There are really two big classifications. Number one is missing the diagnosis of smoldering subclinical rejection. As we all probably know, serum creatinine as a measure of renal function is the only biomarker that we use in renal transplantation today, at least in children, but it is sorely deficient. For example, small recipients of large adult kidneys have a major problem. In spite of sometimes significant rejection activity, the creatinine does not increase because of the large amount of renal reserve. Thus, smoldering subclinical rejection can go on without detection by the serum creatinine. Moreover, as children grow, they add muscle mass, which leads to an increase in creatinine. So we always ask ourselves when we see this, is this physiological changes, or are we actually watching smoldering subclinical rejection? Another unique clinical characteristic that leads to smoldering subclinical rejection are the facts that children may be unknowingly under immunosuppressed as time goes by. For example, if a child is growing, the tendency of the medical team is still to keep the immunosuppression unchanged rather than serially raising the medications pegged to the child's size, BMI, or height. This may lead to under immunosuppression and subsequent rejection. Moreover, and this is probably the big bad actor, as many as 65% of adolescents manifest significant non-adherence, leading to unrecognized under-immunosuppression and subclinical rejection. This is a particularly large problem, certainly in adolescents, but also perhaps unknowingly in adults. This is a slide I always like to show when I'm giving a talk like this. A study in transplantation about almost 10 years ago now from Beth Foster. And what Beth showed is that after the first post-transplant year, adolescents have the highest graft failure rates of any age group. As you can see, this is the incidence of graft failure at a specific age, not when the patient was transplanted, but at the age the patient is now. And as you can see on the top half of the graph, at any time, the patients that are in mid-adolescence to young adulthood have the largest graft loss. Moreover, if you factor and take the data out from the first year and put only those patients that made it through the first year, you can see again that the large, significant number of patients that are failing allografts are greatest in the mid-adolescence to young adulthood. And this is the fact of graft loss is the most in any age group. So a number of us have been asking the question, can protocol biopsies or validated biomarkers help uncover adolescent non-adherence and help block this loss, this huge loss of transplants? So the question comes up, who does protocol biopsies? How many of us in pediatrics have actually gone to it? I'll not be commenting on what the adults do. This is just what we do in peds nephrology. And this is a very unscientific survey. I basically just went on our listserv and said, okay, how many of you do protocol biopsies? Period. I didn't want to tax people too much because they wouldn't answer the survey. And as you can see, I got 67 responses over about 3 or 4 days. Of importance, shown in red, is that in the United States, about 38% of centers perform protocol biopsies. And overall, when we take in the world who answered, 34% of the centers perform protocol biopsies, and 66 of the centers do not. In North America, both US and Canada, 43% of the centers perform protocol biopsies. This is the gold standard biomarker that we've all been using for the last 10 to 15 years. Now, we looked in a study that I published about 2 to 3 years ago in HAT. We looked at subclinical alloimmune failure events. And by that, I define that as either biopsy-proven rejection or de novo DSAs. And we did protocol biopsies in 106 pediatric renal transplant recipients at 1 year and 6 months. And we combined the data together, and what this showed was that in 22 of the 106 patients, there were de novo donor-specific antibody. Moreover, when we did biopsies in patients that had no elevated creatinines and no signs of rejection, 24 of the 106 had some evidence of inflammation or mostly T-cell mediated rejection. Of those 24, 14 had only borderline changes. Again, subclinical inflammation. 7 patients had both donor-specific antibody and biopsy proven rejection. So why is this important? Mike Seifert showed that in pediatric renal transplant recipients, subclinical rejection in whatever form in protocol biopsies are associated with a significantly increased incidence of biopsy-proven rejection and or allograft loss at 5 years post-transplant. So these kids are certainly at risk, and this is the reason that the centers do the protocol biopsies. Moving on, the question comes up, what are the emerging biomarkers in transplantation that have relevance to pediatric renal transplantation? And again, I would like to focus your attention on what is shown in red. And what is shown in red right now is that I've listed under the biomarkers peripheral blood, serum, and urine tests. I've listed in the middle the reliability of those tests as manifested by the AUC of the validation studies. And then I have some comments that I will just briefly go through. The short answer to all of this is there are really only 2 pediatric studies that have ever looked at any biomarkers other than creatinine. One is de novo donor-specific antibody, and there are pediatric studies that have looked at this. It's not very sensitive. For that matter, it's not as specific as we would like. And the association with de novo DSA is associated with antibody-mediated rejection. Tom Bled-Hansen, one of my ex-fellows and now a real luminary in the area of biomarkers in pediatric renal transplantation, studied CXCL10 protein in the urine and showed that there was a high positive predictive value for the urinary CXCL10. To my knowledge, this is the only study that has looked at just pediatric patients. Now, if we look at Mini Sarwal's case sort, the second entry on the biomarker page, or if we look at CXCL9 RNA or protein, shown by workers who have been in the CTOT study, children were examined, but the children weren't separated out and looked at separately. So while children sort of officially are in these studies, there really is no good data that tells us whether we can use these biomarkers in pediatrics to examine or to look for subclinical rejection. I've listed the others there for you. The other thing I'd like to sort of focus you on is the fact that most of the biomarkers that have been looked at in adults, essentially, have been those with high positive predictive values, whereas TrueGraph has a high negative predictive value. And we're going to look in just a minute at how that may help us in pediatrics when we try to discriminate those two. Now, if we look at biomarker predictive values in pediatric renal transplantation, and I make the warning that I am by no means a biostatistician. I am the village idiot when it comes to biostatistics. However, it's easy enough to understand that if there's a positive predictive value, this will help us identify the percentage of individuals who have a positive test. Those actually have rejection or graft inflammation if their positive predictive value is within the relevant range. On the other hand, the negative predictive value expresses the value of the true negatives. Namely, if a test is negative, then the negative predictive value yields the percentage of individuals with a negative test who do not have rejection or graft inflammation. Put another way, the question can be asked, does a negative result truly mean that there is a high probability of the absence of rejection? The higher the test's negative predictive value, the more likely that a negative predictive value, that negative predictive value indicates that the patient is adequately immunosuppressed. And I stress those words, adequately immunosuppressed and unlikely to have subclinical rejection. As I pointed out before to you, the major problem we have in pediatrics is knowing that a patient has adequate immunosuppression on board. Thus, the result of a negative test in an assay with a robust negative predictive value would indicate whether the immunosuppressive regimen a pediatric patient is taking is sufficient to prevent rejection activity. Now, I mentioned TrueGraph before, and it's important to note that TrueGraph does not provide a prediction of whether there is rejection, actual rejection, in the transplant, because the positive predictive value is relatively low. The negative predictive value is quite high, but the positive predictive value is not particularly dramatic. Thus, it may be possible to consider pairing TrueGraph with a test with a high positive predictive value to get a full and complete picture. However, the high negative value in a test like TrueGraph provides a statistical assessment of the probability of whether there is no rejection activity, namely immune quiescence. And that's really what we're looking for in our patients. So how might a robust biomarker program affect management of the unique challenges in pediatrics? Well, suppose we have suspicion of medication non-adherence. In adolescence, it's very, very frequent. I like to say that whenever you have a statistic in patients of non-adherence, you always want to double it for the actual realistic amount of non-adherence. So I said before that 65% of adolescents are officially identified as non-adherent. If you double that, it means over 120% of adolescents are non-adherent. I think you get my point. The problem, of course, with non-adherence is that there is possible immunosuppression. So how would we apply a biomarker in this situation? An assay with a high negative predictive value would be very useful here, because if the result is in the negative range, this would indicate no rejection and that the patient is sufficiently immunosuppressed. Thus, no biopsy would be necessary. And again, I'm pointing this to only patients that are clinically quite stable. What about when the serum creatinine increases with growth or increased muscle mass? This happens mostly in prepubertal children that are transiting into adolescence, and this happens very frequently. And we look at the serum creatinines and we say, oh my gosh, do we need to biopsy this patient? And we often do. The increased creatinine leads to concern that there is subclinical rejection episode. Thus, an assay with a high negative predictive value would be useful, because if it's in the range of negativity, then there is likely to be no rejection, and we don't have to chase a marginally high increased serum creatinine. No biopsy is necessary because the patient is sufficiently immunosuppressed. What about the failure to adjust immunosuppression upwards with growth? Again, this happens in prepubertals and adolescents, mostly in this situation as prepubertals are transiting into teenagerhood. The problem, again, is possible under immunosuppression. And if the result is in the negative range again, there's no rejection and the patient is sufficiently immunosuppressed with no biopsy that's necessary. You can see there's a bit of a theme here of wanting to uncover the possibility of under immunosuppression. Under immunosuppression that may not have mediated any clinical changes, even subtle clinical changes. And so if you can avoid the biopsy because you can feel fairly confident that there are none of these subtle clinical changes, you're ahead of the game. Finally, there's the situation in children around and less than 5 years of age when we transplant a large adult kidney into small children. In this situation, rejection activity may be missed because creatinine fails to increase because of the large renal reserve. In this situation, you'd probably most likely to have an assay with high positive predictive value. In this situation, if the result is in the positive range, there's a occult rejection and biopsy is probably necessary. This is quite common in the very little kids that we see. Well, we don't do many of them because most of the transplants are done in the kids 6 to 12 and 12 to 21. That's when most of the pediatric transplants are done. The younger ones create this sort of problem. So finally, a few caveats and conclusions. With few exceptions, biomarkers with both positive and negative predictive values have not yet been validated in pediatrics. And so everything that you've heard today has to be regarded as speculative. It's possible that a test with a significant negative predictive value, such as TrueGraft, while potentially quite useful, can be improved by pairing it with a test with a significant positive predictive value, such as CXCL9, CXCL10, or donor-derived cell-free DNA. But most importantly, biomarkers with a robust predictive value have the potential to substantially improve the clinical management of some important conundrums in pediatric transplantation that we all have been faced with for a lot of years, and have to answer the questions with protocol biopsies. These biomarkers can potentially avoid the use of many protocol biopsies, and probably in terms of proportionality, we have more of these patients proportionally than do adults in their clinic because of the reasons that I told you. Now, currently validation for TrueGraft and others, including a few positive predictive value studies, are currently ongoing, not just with my group, but with a number of other groups. That ends my talk, and I want to thank you all very much for listening, and I'll be glad to answer some questions.
So Dr. Ettenger, that was an excellent presentation, and you've very succinctly highlighted the unique challenges that face clinicians in managing pediatric patients. But with regard to the non-adherence, how frequently do you think you would have to monitor biomarkers in a pediatric patient to identify possible medication non-adherence?
John, that's the big question. We've been doing transplants in children and adolescents for over 50 years. And we really don't have a good answer to how long non-adherence has to be going on to give you graft dysfunction. What happens in reality in the real world is that centers, after 1 to 2 years, see patients every 3 months. And what happens is that after one of these 3-month interregnums, the patient comes in, and the creatinine, instead of being 1.5, is now 5.5, and the patient's hypertensive, et cetera, and you're well on the way to losing that allograft. But you can't see them every 2 weeks or every month, even though you certainly would like to. So what it boils down to is what are going to be the performance characteristics of the biomarkers that you're going to talk with, and how easy are the samples to get, and how expensive is the test, and how practical it is to be able to monitor them more frequently than what you're seeing. Once we're going to need to do studies to be able to learn just how often it's going to be that this is going to be really the most helpful.
So thank you. So would a patient non-adherent with his medication regimen be actually compliant with the biomarker testing program?
Absolutely. The truth of the matter is they would. These kids come in every 3 months. They tend to forget their medicines for all numbers of reasons. And when they come in, they market themselves to you as being totally compliant. So you only learn that there's a problem when there's a huge problem. If you were able to draw bloods at home, or get urine at home, or get something in a close lab to where you live, and we're able to see the doctor rather than every 3 months, maybe every 5 months or 6 months, because you're monitoring them with reliable biomarkers, the adolescents would love that. And you could even do your visits, your clinic visits, if you will, virtually. So yes, I mean, the biomarkers will make following patients a whole lot easier.
And one last question. Bob, would you comment on the possibility that TrueGraft testing or other biomarker testing in a non-compliant adolescent would teach us something about operational tolerance?
That's a very interesting question. We have patients we know are not taking their medicines, and yet their creatinines stay relatively constant. And so the question is, but frequently we don't know how non-compliant they are, or really truly if they're compliant or non-compliant. And the biomarkers of whatever stripe can help us determine what patients we need to look at more closely with immunologic testing and T cell phenotyping, B cell phenotyping, et cetera. But rather than do these on all the patients, some of whom are on immunosuppressive medicine, some are not, if we can denote that the biomarkers help us figure who the patients are who are adequately immunosuppressed, but are not taking their meds, those are the ones we want to study.
So that's very interesting. It's some of us have been around long enough to have this as a goal for a long time. Maybe the molecular markers and other markers will be the tool that will let us gain insight into this process. Thank you very much, Dr. Ettenger, for your remarks. And that concludes our program today. We really appreciate everyone joining us and hope that you found the presentations helpful. If you have any questions, please don't hesitate to reach out and contact me at Transplant Genomics. My email address is johnholman@eurofensus.com. And again, I want to thank you for your time, and I wish all of you to be well. Thank you.